Welcome to PGOG, postgraduate class in obstetrics and gynecology for postgraduates as well as consultants of obs and gynae. Today's topic is diabetes in pregnancy, its types and diagnosis. Now we say that pregnancy is a diabetogenic state. And in India, we have a high diabetes mellitus prevalence. Diabetes in pregnancy adversely affects baby as well as mother. Every festival or celebration in India, it has a sweet food base. Now, what is happening is there is more and more patients we are getting with diabetes in the younger age group also. And the reasons are with the new generation, there are late marriages, late conceptions, decision to proceed with the pregnancy is also sometimes delayed. There is a sedentary lifestyle, fast food based faulty dietary habits are there, and with that there is a rising obesity as well as metabolic syndrome, and all these together are responsible for rising prevalence of diabetes in India as well as diabetes in pregnancy. So we need to take diabetes in pregnancy seriously. What is happening to carbohydrate metabolism in normal pregnancy is there is a fasting hypoglycemia which is mild, but it is always there, fasting hypoglycemia as compared to the non-pregnant state, and it is because of the fetal glucose consumption throughout night. On the other hand, there is a post-meal hyperglycemia during pregnancy, and there is an overall hyperinsulinemia. Insulin is definitely raised during pregnancy as compared to the non-pregnant state. Why there is hyperinsulinemia is because of the pregnancy-induced increased insulin resistance. Insulin resistance is more, and that leads to the more and more secretion of the insulin by pancreas, leading to the hyperinsulinemia during pregnancy. Now, this insulin resistance it has a progressive increase in pregnancy, so that as the pregnancy advances, there is more and more insulin resistance. Gestation diabetes mellitus detection, that is why it is more in the second half of pregnancy, because as pregnancy advances, insulin resistance keeps on increasing, and that is the reason why more and more maximum number of women are diagnosed with diabetes in pregnancy in the second half of pregnancy. Insulin requirement, if patient is already on insulin requirement also increases with advancing pregnancy because of this increasing insulin resistance with the progress of the pregnancy. So why insulin resistance increases with pregnancy is the most important is there is a secretion of anti-insulin placental hormones. Placenta is secreting the hormones which have a action which is insulin antagonistic action, and these hormones are, there are so many hormones such as progesterone, estriol level increases, growth hormone is secreted by placenta, prolactin is secreted, cortisol plays an important role as an insulin inhibitor, and human placental lactogen. All this together, these placental hormones, as the placenta increases in size with advancing pregnancy, the level of all these hormones keeps on increasing with advancing pregnancy, and that is the reason with advancing pregnancy there is more and more insulin resistance. With pregnancy, there is an increased fat deposition in pregnancy. Overall adipose tissue in the body increases in the mother, and this increased adiposity leads to the more level of leptin. Leptin is the hormone secreted in the adipose tissue, and leptin also has a anti-insulin action. It is also insulin antagonist. Third is there is a pregnancy has a associated with a inflammatory response. There is a chronic inflammatory response in the mother with the pregnancy, so that there is an increase in secretion of cytokines, especially tumor necrosis factor, and other cytokines are increased, and these cytokines also have got an antagonistic action on the insulin. So for postgraduate students, what you should remember is it is not only the placental hormones, but associated with that increasing leptin and increasing Cytokines are also adding to the action of these placental hormones as insulin antagonist. And overall, there is a progressive insulin rise in the insulin resistance throughout pregnancy. Along with that, there is increased insulin destruction by the placental insulinase. Placenta is also secreting a hormone insulinase, which is leading to the excessive destruction of the insulin which is present in the body. With that, there is increase in hepatic gluconeogenesis in pregnancy, and pregnancy is typically described as a state of accelerated starvation. What is happening is whenever there is a overnight fasting, metabolism in the mother is shifting from carbohydrate based metabolism for the energy for the energy acquisition to gain the energy. From carbohydrate it shifts to lipid. So what is happening because of that is there is low sugar level in the blood, but there is increase in free fatty acids and cholesterol. That is why it is called as an accelerated starvation state in pregnancy. Prolonged fasting leads to early ketonemia in pregnancy, and that is why there is an increased risk of ketoacidosis whenever a patient has got a type 1 diabetes mellitus. Increased risk of ketoacidosis because of pregnancy itself, the changes, physiological changes are such that the metabolism is shifting from carbohydrate to fat. And that is why there is a situation as if like an accelerated starvation situation where adding to the diabetic ketoacidosis, there are changes of starvation ketoacidosis are also. And that is why there is an increased risk of ketoacidosis whenever a patient has got especially type 1 diabetes. So as we can see here, this white one is a non-pregnant, how the glucose level is happening, blood glucose level changes, fasting and postprandial. But in pregnancy, fasting is lower because of the fetal consumption of the glucose throughout night. And postprandially, there is a hyperglycemia because of this hyperinsulinemia and insulin resistance. What is the advantage of these physiological changes? That there is more glucose which is remaining in the blood, and there is a insulin resistance is there, so glucose is not entering into the cells and it remains for a with a greater degree in the blood circulation. So increase insulin resistance, more blood glucose available for fetal consumption. That is one as advantage, that baby gets more blood glucose. In response to this increasing blood glucose, there is secretion of insulin by the fetal pancreas, and insulin acts as a growth hormone. So better fetal growth as insulin is acting as a growth hormone. So fetal growth ultimately is better because of these physiological changes in the carbohydrate metabolism in pregnancy. That in the mother there is more of glucose because of the insulin resistance which is going transplacentally to the fetus. In response to this glucose, fetus is secreting more insulin. Insulin acts as a growth factor, leading to the better fetal growth. HAPO, that is hyperglycemia and pregnancy study. That is a landmark study which, on the basis of which in 2010, new recommendations were proposed to understand the diabetes in pregnancy. As we say, MACPA study for hypertension in pregnancy is a landmark study. Similarly, the postgraduate students, you should all remember that whenever you are discussing diabetes in pregnancy, you must mention this study because it has changed the way we classify this disease. It has changed the way we diagnose this disease as well as we treat diabetes in pregnancy. So this is a landmark study which goes by the name of HAPO, that is hyperglycemia and pregnancy outcome. It was a study which was conducted over 7 years, and it was an international study which was conducted at 15 different centers all over the world in various countries, and 23,000 women were studied under this HAPO study. Universal screening for all pregnant women was done with 75-gram oral glucose tolerance test at 24 to 28 weeks, and outcome was studied. What was mainly seen was more and more increasing blood sugar level was associated with worsening prognosis is was the one outcome of this study. But what was very important was this International Association of Diabetes in Pregnancy Study Group, IAD-PSG. This organization had provided us with the recommendation in 2010, which are mainly based on this HAPO study. Most important is their recommendation is they are recommending one-step approach for the diagnosis of gestational diabetes or diabetes in pregnancy by providing 70 gram of glucose and oral GTT, glucose tolerance test, where we estimate the blood glucose at the end of 2 hours. So it is 75 gram 2 hour GTT was advocated by this, where blood glucose is taken as fasting 1 hour, 1.5 hours, and 2 hours. I'm sorry, fasting 1 hour and 2 hours. And any one of these three is raised, then it was considered as diabetes. That was the one recommendation, that you give 75 gram glucose, and then fasting is taken, as well as 1 hour, 2 hour is taken, and out of these three, any one is positive is considered as suggestive of diagnosis of gestational diabetes. What is most important outcome of this HAPO study is it helped this organization IAD-PSG to give the recommendation that we should divide gestational diabetes mellitus into two subgroups. One is probable overt and other is pregnancy induced or because of the pregnancy changes gestational diabetes mellitus. So that is the most important takeaway from this study. And for postgraduate students as well as consultants, I want all of you to notice that after 2010, the thinking about this disease had changed a lot. That even if it is a gestational diabetes diagnosed for the first time in pregnancy, we should further subdivide it into probable overt and pregnancy-induced gestational diabetes mellitus. I hope this point will get more clear as we proceed with the subsequent slides. So mainly there are two types based on this HAPO study, which were suggested in 2010. First is pre-gestational or overt diabetes, which is diagnosed before pregnancy, where it can be of type 1 or type 2. Second is gestational diabetes mellitus, which is diagnosed for the first time during pregnancy, but not clearly overt. That means there are no features which are suggesting that it has got a possibility of overt either type 1 or type 2. Gestational diabetes mellitus is defined as carbohydrate intolerance of variable severity, any severity, with the onset or first recognition in pregnancy. So either it is onset is in first time in pregnancy, or it is recognized for the first time in pregnancy. But what is most important, after 2010, what has been added is there are no features of overt diabetes mellitus. Though it is diagnosed for the first time, it is not associated with any features of possibility of overt diabetes mellitus. Importance of gestational diabetes mellitus is more than 50% develop diabetes in the next 20 years, and babies of GDM have increased risk of obesity and diabetes in adult life. Now, what is this recognizing this probable overt in GDM? Now, if this is a group of GDM, a small group is there which is having a probable overt DM as the diagnosis. GDM is diabetes mellitus diagnosed for the first time in pregnancy. But there is a small subgroup in GDM who have clear features of overt or pre-gestational diabetes mellitus. So for that, there are 4 criteria are there to diagnose a case of GDM as probable overt. So GDM itself, we have a small subgroup which is probable overt. These criteria are only applicable for women who are not diagnosed as diabetes before pregnancy. So what are these criteria? There are 4 criteria to have a probable diagnosis of overt diabetes mellitus in pregnancy, and any one of these 4 is sufficient to diagnose it as a probable case of overt diabetes mellitus. Suppose a patient comes to us in OPD and we are investigating her and screening her for the presence of gestational diabetes mellitus. In that patient, if any one of these 4 is found, you diagnose it as gestational diabetes mellitus with probable overt diabetes mellitus. That is what I want to stress again and again. So according to this 2010 IID PhD criteria, anyone, either if her fasting plasma glucose is found to be more than or equal to 126 milligram per day, fasting more than 126, that is one, or random blood glucose anytime you are doing and it is more than or equal to 200 milligram per dl with other clinical features such as polyuria, polydipsia, or unexplained weight loss. Or third is glycosylated hemoglobin, which is more than or equal to 6.5% in first trimester. So that was the recommendation which was given on the basis of HAPO study, which was given in 2010. WHO has added one more criteria in 2019, which was also approved by American Diabetic Association in 2020. One more criteria which has been added is if plasma glucose 2 hours after 75 gram glucose load shows a level which is more than 200 milligram per day. So post glucose after 75 gram after 2 hours, if the patient's blood glucose, plasma glucose level is more than 200 milligram per dl, then that is also sufficient to diagnose that patient as a case of gestational diabetes mellitus with probable overt diabetes. This why we are calling it as probable is this needs postpartum confirmation. Once patient delivers, then after that, after 6 to 12 weeks of delivery, we need to do the investigate the patient again, do the GTT again, and then that will confirm that whether she has a over diabetes. But there is a strong possibility, and that is why we need to segregate or separate these women and treat them separately as compared to the other women who are not having any of this one of these 4 criteria. Those will be gestational diabetes mellitus, where there is a diabetes which is because of the exaggerated physiological changes of pregnancy, or there is a response, maternal response to the physiological changes of pregnancy is not up to the mark. Mother is not being able to, or maternal pancreas is not secreting enough insulin to combat the insulin resistance in pregnancy. That will be patient who has pregnancy induced diabetes mellitus. But in GDM, gestational diabetes mellitus, there will be always be a small subgroup where they will behave like over diabetic. That is why we need to diagnose them by any one of these 4 criteria is the most important takeaway message by today's lecture to all consultants as well as to all postgraduate students. What is the importance of identifying probable overt diabetes mellitus in gestational diabetes mellitus? Probable overt DM needs treatment exactly as overt diabetes mellitus, and prognosis is also poor in probable overt DM as compared to gestational diabetes mellitus without any of these features of overt DM. So we have clinically, in short, again, to repeat the same thing, we have 3 types. One is pre-gestational or over diabetes, where clearly the diabetes has been diagnosed before pregnancy and patient has either a type 1 diabetes mellitus or type 2 diabetes mellitus. Then we have a group where second is probable overt diabetes. That means they are diagnosed for the first time in pregnancy, but they are fulfilling any one of the 4 criteria. I will repeat again. Fasting more than or equal to 126, random more than or equal to 200, glycosylated hemoglobin more than or equal to 6.5, or 75 gram glucose post glucose 2-hour plasma glucose level more than 200 milligram per dl. then any of these four, one of these four, she becomes a patient becomes a case of probable overt DM, where the treatment and the prognosis are same as overt diabetes mellitus. And there is a third group who are not fulfilling any one of these four criteria, who will be labeled as GDM, gestational diabetes mellitus. Now, since so many decades, and even I was doing post graduation, I was also studying this classification. It is since many decades this White's classification was used to classify the women having diabetes during pregnancy, where type A is gestational diabetes, A1 is abnormal GTT, but fasting and postprandial is normal, whereas A2 is abnormal GTT, and either one of these two or both are abnormal, fasting or postprandial blood sugar. Type B is diabetes after 20 years, but duration of less than 10 years. That means it is a over diabetes, but the onset is late. Type C is where it is from 19 to 10 to 19 years, and as well as duration is 10 to 19 years. Type D is before 10 years and duration of more than 20 years. E is where there is associated calcified pelvic vessels. F is diabetic nephropathy. R stands for retinopathy. FR is when patient has both nephropathy as well as retinopathy. H is for ischemic heart disease, and T is patient has prior kidney transplant. That was the White classification, which was also classifying the women as per the various complications of overt diabetes. Now, there is a simpler classification which has been proposed by American Diabetic Association in 2010. It is a proposed new classification of diabetes and pregnancy, where they have made it easier by having only three types. One is gestational diabetes, which is the diagnosis, first time diagnosis in pregnancy, and there are no clear features of overt diabetes. If there are features of overdiabetes, or if it is diagnosed as a pre-gestational diabetes mellitus, then it will be type 1 or type 2. Type 1 is because of beta cell destruction with absolute insulin deficiency, type 1. Type 2 is when there is a inadequate insulin secretion in the presence of increased insulin resistance. So it is mainly the insulin resistance which is the culprit for type 2, whereas there is a less pancreatic problem is type 1. Both of these are further subdivided as A and B. A stands for without vascular complications, B stands for with vascular complications. So this is a simpler new classification which has been proposed in 2017, where type 1, it is based on whether their problem is at the level of insulin or problem is at the level of insulin resistance, at the level of pancreas, or problem is at the level of insulin, peripheral problem of insulin resistance. That is type 1, type 2 and gestational diabetes. But what is most important is there are no clear features of overt diabetes mellitus, or patient is not having any one of the four criteria to call her as a probable overt diabetic. Vascular complications in diabetes are either microvascular or macrovascular. Microvascular complications lead to neuropathy, diabetic neuropathy, retinopathy, nephropathy. Macrovascular complications lead to ischemic heart disease, stroke, or peripheral vascular disease. Now this diagrammatically we can remember that way. Type 1 is pancreas, it is not secreting insulin. There is a deficiency, absolute deficiency of insulin, and that leads to the more of blood glucose level in the blood vessels. Type 2 is where insulin is getting secreted normally, but peripherally there is a insulin resistance, so that glucose cannot enter into the by insulin receptors in the cell. So that is the reason why glucose remains unutilized, and that leads to the hyperglycemia or more and more presence of glucose in the blood vessels. So this is to make diagrammatically our ideas clear how to differentiate between type 1 and type 2 overt diabetes mellitus. Now, what is the correct method of diagnosing diabetes mellitus is Now, whether we are testing serum or plasma is always when we do the blood glucose. Majority of the laboratories are doing it, diagnosing diabetes by testing the plasma glucose. Serum is the liquid part of blood after clot formation. Serum glucose levels are not measured. In the majority of the tests or labs, what we are measuring is plasma. Plasma is the liquid part of the blood after addition of an anticoagulant. Capillary blood is tested whenever we are using glucometer. Venous blood is tested whenever we are doing phlebotomies or we are withdrawing the blood from a vein. Post-meal capillary blood glucose level is 20% higher than venous blood, as glucose is utilized by the tissues. By the time the blood leaves capillaries and goes to the veins, tissues are consuming glucose, and that is the reason that venous blood will be 20% lower as compared to capillary blood. That we need to remember whenever we are using glucometer. Venous plasma glucose estimation is used for diagnosis. If you are asked how do you diagnose blood diabetes, which way method you will go for, whether you can use glucometer, your answer should be no, because glucometer will be testing only the capillary and glucometer needs to be calibrated. So first time diagnosis is always what is advisable is to go for venous plasma glucose estimation. So always we use the whenever you are using the terminology, don't say blood glucose, especially for the diagnosis of gestational diabetes mellitus. Also, whenever we are, whatever we are testing is the venous plasma glucose. Glucometer calibrated can be used for self-monitoring. Once you diagnose, then glucometer is the best to monitor the blood sugar. Now, why we should differentiate between overt and gestational diabetes mellitus? Overt diabetes with vascular complications has worse prognosis. CVS or renal involvement because of diabetes mellitus carries poor prognosis. Mother is having already ischemic heart disease or already mother has renal disease, then the diagnosis is poor. Uncontrolled overt diabetes mellitus will always have a bad prognosis. Maternal and perinatal complications are more with gestational diabetes mellitus as compared to normal women not having gestational diabetes, but obstetric complications are more in overt diabetes as compared to gestational diabetes mellitus. Obstetric complications are maximum whenever the patient has got overt diabetes with vascular complications, whether it is type 1 or type 2. If vascular complications are there, then the prognosis worsens. And vascular complications are more common with a long-standing diabetes, which is more common with a type 1 diabetes. So this is again pictorially we can understand that the obstetric complications, they are so much in normal. They are definitely more in gestational diabetes mellitus. But with overt, there is further increase and type 1 has more complications as compared to type 2. But whenever it is over diabetes with vascular complications, then it has a worse prognosis. Complications are maximum. They keep on increasing gradually from GDM to overt, but from overt also, as compared to overt with complications will have larger number of obstetric complications. Now, diagnosis of gestational diabetes mellitus is associated with many controversies. So, what are the controversies are? Whether we should diagnose it as a one-step or two-step approach, whether we should be using 75 gram or 100 gram glucose load whenever we are diagnosing it as a one-step approach, what should be the cutoff value, whether it should be 130 or 140 whenever we are doing a two-step approach, whether we should screen it as a universally for all pregnant women or we should be focusing only on the high risk group for the screening for gestational diabetes, and whether we should test after or before 24 weeks of pregnancy. So these are some areas of controversies, and you can see that so many points are there, and that is why the diagnosis is clouded. And if you see the literature from country to country, the guidelines keep on changing. The guideline for the diagnosis COG will be different. ACOG will be different. Australian will be different. Canadian will be different. Indian will be different. So all these are because of there are so many issues which are associated with the diagnosis, and these are the issues which are adding to the diagnostic controversies for the diagnosis of gestational diabetes mellitus. Now, what is this one step and two stage approach? Step approaches. In the one step approach, you test the patient, investigate get the patient in single sitting, and then you decide whether patient has diabetes or not in pregnancy. So either we can give 75-gram oral, do 75-gram oral GTT where we do fasting 1 hour and 2 hour. 3 times we are testing, and any one of these three is raised is sufficient to diagnose the patient as having gestational diabetes mellitus. Or we can go with 100-gram glucose tolerance test where there are 4 times we are testing the blood plasma glucose, fasting 1 hour, 2 hour, 3 hours, and any two are raised, then it is considered that patient has gestational diabetes mellitus. So whenever you want to test the patient, you do this one-step approaches. In a single test only, we can differentiate whether, or we can say whether patient has gestational diabetes or patient is not having gestational diabetes mellitus. What is two steps? So all this is true for patients who are not having overt or pre-gestational diabetes. That is what I want to stress again, that we are talking about gestational diabetes mellitus means we are diagnosing diabetes for the first time during pregnancy. What is two-step approach is 50-gram glucose load is given. It is also called as O'Sullivan test. If you are asked in exam what is O'Sullivan test, 50-gram glucose is given irrespective of patient's previous meal or the time of the day. Anytime she comes to the OPD for checkup, you give 50-gram glucose load orally, and 1 hour later you do the venous plasma glucose estimation is done. If it is more than 140, it is an indication to then further do the complete GTT by either 75 or 100-gram GTT. That means we are screening all the patients with O'Sullivan. Those who are showing more than 140, those only are going for complete GTT. You are not doing GTT for each and every patient, so that the lab load reduces with that. And secondly, the number of patients who are going diagnosed with this two-step approach less, so that less false positives will be there. Whereas one-step approach, there is a possibility of having more false positive. That means patients not having diabetic might also be diagnosed as diabetic. So two tests we are subjecting the patient to. Two step is two tests. First step test is this O'Sullivan and then GTT. Now, specificity to diagnose of the diagnosis of diabetes is more is with 140 as compared to 130, and that is why most of the guidelines are allocating that for O'Sullivan, what we should do, take it as a cutoff point is 140. Now, this is the chart, and I think this should be displayed in every OPD, and whether you are going with 75-gram or 100-gram. But if you are whatever you are going with, remember 75-gram, then the values are 92 and 180, 153. Any one of these three more than that is diagnostic of gestational diabetes mellitus. If you are using 100-gram, then it is called as Carpenter and Coston criteria, where the values are 95, 180, 155, and 140. Any two of these four is required to diagnose a patient as having GDM. Now, American College of Obstetrics and Gynecology 2019 recommendations are with the one-step approach. One-step approach increases the number of women diagnosed as GDM as compared to, I'm sorry, they are not recommending one step, but what they recommend is what they are recommending is two-step approach. And the reasoning why they are recommending two-stage approach is one-step approach increases the number of women diagnosed as GDM as compared to two-stage approach, as we have already seen in the last slide, but no reduction in macrosomia related complications with one-step approach. Overdiagnosis or false positives are more if we go with one-step approach. Unnecessary burden on the health facility and unnecessary increase in the cesarean section rate is there, unindicated cesarean section, and that is why ACOG 2019 recommendation is currently they are recommending a two-step approach for the diagnosis of GDM, where you first do O-Sullivan 50-gram test, and if it is showing more than 140, then only patient is subjected to either 75 or 100-gram oral GTT. It is important to identify probable overt DM in GDM. It is again a reminder I have added this, as we have already seen in the initial slides, that probable overt, there are 4 criteria which are given, which are very important for us to differentiate them from the patients who are having a milder form of the gestational diabetes mellitus. Now, this risk-based screening was advocated in by some countries, that if patient has got low risk, that then no testing is required in pregnancy. That means belonging to low risk ethnicity, age less than 25, no family history of diabetes, normal weight, normal birth weight of woman herself, no history of glucose intolerance, no history of suggestive of bad obstetric history because of diabetes, then in these women there is no need to test. Intermediate risk is where screening is required at 24 to 28 weeks, where patient is not having a greater risk than low, but lower than high risk. So we need to understand high risk, where either there is a severe obesity or strong family history of type 2 diabetes or previous history of GDM or glucosuria. These are the women where testing is done as soon as possible at the earliest in pregnancy, and it is again repeated at 24 to 25 weeks if the first antenatal visit testing shows that there is a negative result. India, we belong to high risk ethnicity, so no, this low risk and no testing is out of not an option for us. We come under either intermediate or high risk by this risk based screening. But what we follow at present is in India is a FOXY guideline, that is Federation of Obstetric and Gynec Society of India. They have provided us 2021 latest guideline, where what is advocated is we go by DIPSI test. DIPSI is Diabetes in Pregnancy Study Group India. Diabetes in Pregnancy Study India is DIPSI. So the test goes by the name of this Diabetes in Pregnancy Study Group, and that is why it is called as DIPSI test. This is advocated by this FOXY guideline 2021, where universal screening for all pregnant women is advocated at first antenatal visit. If negative, it needs to be repeated again at 24 to 28 weeks. The reason is, as we have already seen, insulin resistance keeps on increasing. So that with that thinking only, even if first antenatal visit, say in first trimester, you do the DIPSI test and the result is negative, we need to repeat it again at 24 to 28 weeks. What we are doing is a one-step test. 75-gram glucose is given in 300 ml of water over 5 to 10 minutes to the woman, and irrespective of food intake, it should be given. And glucometer-based testing is done after 2 hours. If it shows more than or equal to 140 milligram per day, it is diagnostic of GDM. You don't have to go for any further testing. That is why it is called as a one-step test. If the woman has vomiting within 30 minutes of ingestion of this 75-gram glucose, then the test needs to be repeated. If vomiting occurs after half an hour, there is no need to repeat the test. What are the advantages of this DIPSI test, which is a one-step test, which is being done in India? DIPSI test is also approved by Government of India as well as WHO. The reason why it has it is being advocated is India, we have high prevalence of diabetes as well as diabetes in pregnancy. But there is a less compliance for repeated visits which are required for two-step test. That means you do O-Sullivan and then you ask the patient to come fasting for the next visit to do complete GTT either with the 75 gram or 100 gram, it is not feasible. Practically on ground, it is not feasible for the woman to come for repeated antenatal visits. And that is why if you go by two steps, you will have so many women who are going for, who will be categorized as lost to follow. Patient doesn't have to come fasting is a big advantage of this DIPSI test, because coming fasting and then the OPD starts, say even at 8 or 9 a.m. and by the time you ask the patient to go for the testing, it will be 10 or 11 a.m. in the morning for the patient, and there is already pregnancy has a advanced accelerated starvation state, and patient will be so uncomfortable by that time. So that discomfort is taken care of when we go with this DIPSI test. This test can be repeated easily even in second and third trimester. It is not feasible for women to come for frequent ANC visits, and that is the reason this test in one go, one step test is, it is screening as well as diagnostic test, DIPSI test. What is done is with the first antenatal visit, this 75 gram glucose is given, and 2 hours later we have to see how much is the blood sugar. If it is more than 140, more than or equal to 140 gram per dl, then patient has diabetes, gestational diabetes mellitus, and you start the treatment. If it is negative at first visit, same test is repeated at 24 to 28 weeks. If it is negative, then the pregnancy is considered as a normal pregnancy, not having gestational diabetes mellitus. Whereas if it is positive, she is diagnosed as a patient of gestational diabetes mellitus, no further testing to diagnose her is required. You immediately start treating her as a case of GDM. So 75 gram glucose, it is dissolved in 300 ml water, and after 2 hours we have to do the plasma glucose, venous plasma glucose, or glucometer based also can be done if the facilities are not available, and even glucometer based also showing more than or equal to 140 gram per dl. Treat the patient as a case of gestational diabetes mellitus. That is DIPSI test. Thank you so much. Next class we'll proceed with the complications and management of diabetes in pregnancy.